Hi, I am Dr. Soumyan Dey. I am a consultant uro-oncologist and urologist. I am practicing at Navi Mumbai and Thane. Today I wanted to speak to you regarding kidney stones. During my practice I often find that my patients have queries regarding kidney stones. The most common of those queries are what we are going to discuss today. What they present to us is how they come to us answers the question what are the symptoms of kidney stones. A patient will usually come to me and say that, doctor, I am having a huge pain in my abdomen, it has started towards my back and it is radiating down towards my groin, and this pain is severe. So if you have a severe pain, mind the word severe, if the pain is severe and the pain is started in the loin radiating towards the groin, this area is known as the loin, this is a bract, this is where the kidney lies, and it is going towards your groin, in all likelihood the pain is of kidney stone. This is one most important symptom. The second common symptom is patient may have something what you call strangury, S-T-R-N-G-U-R-Y. What do you mean by this? At the end of voiding, so when the patient is passing urine, at the end of passing urine, he has a severe pain in his lower abdomen radiating towards the tip of the penis and even the testicle sometimes. This is also an important symptom of stones. By the way, when we are discussing today about kidney stones, I want to tell you that kidney stones generally used by common man. As a urologist, what we think about stone is that stone may be in the kidney, it may be in the tube which joins the kidney down to the bladder, which is known as the ureter. It may be in the bladder, it may be towards the outside. So this together for a urologist is urinary tract stone or urinary tract lithiasis. The symptoms which I said just now are usually symptoms of ureteric stones. Ureter being small, it can be blocked by a small stone which comes from the kidney down. So the passage of urine from that kidney gets blocked. That is why ureteric stones comes with severe symptoms. Kidney stones, usually patient has got a sonography for some other illness, maybe pain abdomen or maybe some dull aching pain in the back or maybe during a screening for health checkup, then he comes to me with a big stone in the kidney. This is how a kidney stones come. Kidney stones usually are not very symptomatic. Ureteric stones are very symptomatic, presenting with pain as I said just now and with strangury. Bladder stone patients present with having lower urinary tract symptoms. The same symptoms is in prostate, like going to pass urine again and again, having a pain during passing urine, not able to pass urine sometime. These are the symptoms of bladder stone or a stone blocking the outflow of the bladder. So symptoms of kidney stones, when somebody asks me, I tell him or her the kidney stones are usually asymptomatic. They may be having a dull pain in the loin, or may be accidentally detected on tests done for other unrelated illness. When a patient comes to emergency, it is usually because of ureteric stones. There are three common presentations. One is pain which is severe radiating from the loin to the groin. Another is strangury, which is difficulty during passing urine at the end of micturition, with the pain radiating sometime to the tip of the penis and the scrotum. Thirdly, having a frequency of urination, having a lot of frequency of urination, having to pass urine again and again, and the pain in the lower abdomen. This is the third symptom. Fourth is bleeding. Patient sometimes comes with bleeding, blood in urine. Fifth is infection. Patient sometimes comes with signs of infection like fever and a lot of burning, a lot of difficulty in passing urine. These are the common symptoms of kidney stones. The next question which my patients usually ask is, once they come to know, once their symptoms and they come to me is, doctor, you think it is a kidney stone, but how do you diagnose it? The commonest investigation we do to diagnose kidney stone is ultrasonography. Ultrasonography, sometimes an X-ray of the abdomen, which is known as a KUB X-ray. But the most definitive or the best test to diagnose kidney stones or urinary tract stones is a plain CT scan of the kidney ureter bladder. Plain CT scan seldom ever misses a small stone. A sonography may miss a small stone in the ureter, sometimes a large stone in the ureter also. X-ray will not see stones if the stone is radiolucent, means the calcium content of the stone is less, so many times the stone will not be seen on the X-ray. So although X-ray and sonography are commonly used investigation, a CT scan is the best investigation. So if a patient comes to an emergency with a pain, once I give him pain relief, he asks me what test do I do, I suggest plain CT scan is the best. Plain CT scan means a CT scan in which drug is not given, contrast, which is not required for detection of stone. So this is how we diagnose kidney stone, by doing a sonography or X-ray or a CT scan, which is best investigation to diagnose a stone. Now once we diagnose the stone, the next question is, doctor, how do we treat the stone? Now first thing is we have to know about treatment is symptom relief. So when somebody has pain, I have to relieve a symptom first. Second, I have to see whether the stone will pass by itself, how can I aid in the passage of stone, and the third, I have to see that if do I require, if any intervention to remove the stone. So first is pain relief. Now the most important common drug for pain relief I use is paracetamol. Paracetamol is so safe for the kidney, so without looking at the renal function, I can give the patient paracetamol. Because the other common group of drug, which is painkillers, Bovarin, diclofenac, aceclofenac, the class we know NSAID, Meftal, Dotinam, they have all NSAIDs. Now NSAIDs I don't prefer giving to stones because I do not know the renal function of the patient before I have run some blood tests. So without knowing the renal function, without knowing the status of his diabetes, it is better to give a painkiller which has minimum propensity or no propensity to damage the kidney. So I start with paracetamol. If my patient do not benefit with paracetamol, they still have pain, I give buterfenol. Buterfenol is an injection which is an opioid, is also a very good drug in my practice to give pain relief. 99.99% of my patients get relief with buterfenol, sometimes 1 cc, sometimes 2 cc, which is given in IV injection. So this is pain relief. So paracetamol most preferred. Second, I use opioid. Buterfenol rarely, if once I give this painkiller, I send the patient's creatinine values, patient's diabetes status, the patient is non-diabetic, creatinine value is good, then if there is no pain relief with buterfenol or paracetamol, which is very rare in my practice, I give a NSAID, which is usually diclofenac. So this is one part. The second part, stone pain is associated with vomiting most of the time, so I have to give a antiemetic, that is MSET. So this is pain part. The second question is, patient asks me, doctor, do I need to get admitted? If the pain relief is good, patient is not having vomiting, I don't admit the patient. I evaluate the patient on OPT basis. There is no role of admitting him and giving him IV fluid if he can drink orally. It's just logical. If I drink fluid orally or Fetacon IV, both is going to be passed out of the kidney by means of diuresis. So if I am not vomiting, I am not having nausea, there is no reason why I should admit that person to give hydrotherapy, which is commonly used term, or IV fluid. I will just ask him to go home and take a lot of fluid till his investigations come back. Now the next important drug after painkillers which I give is an alpha blocker. The alpha blocker, tamsulosin, silodosin, alphazocin, they are very good in relieving kidney pain. How? Because they relaxes the tube which drains from the kidney down to the ureter. So the ureter is relaxed. By the side of the stone, urine from the kidney can pass down into the bladder. So the kidney is not over distended anymore. By the way, why pain occurs because of the stone? It is not because of the stone moving which causes the pain. It is because the stone coming out from that bag, which is the kidney, and blocking the passage is a small tube around 5 mm to 6 mm, that is the ureter. So if the ureter is blocked, so that kidney is distended with urine, and this distension causes the pain. Although the other kidney is producing urine, the kidney knows there is a stone is distended with urine. So this part is this. So this is one part. Now admissions indication, I told, somebody is vomiting, somebody has, for example, stone in both kidneys. So for somebody, when the stone is both kidney outflow, ureteric bilateral stone, it is a medical emergency, which is a obstructed renal failure. There may be no urine output at all. So if both kidneys are blocked, there may be no urine output at all. So I have to admit it's a medical emergency. Otherwise I don't admit. Now once this part, his emergency part is taken care of, pain, minimum evaluation, tamsulosin has been given, I have checked his blood pressure, his pulse rate, his AGT, that is sugar, which are the normal things. I have evaluated if there is no other cause of pain. Sometimes I had seen patient coming with pancreatitis having severe pain. So along the tests I run, I do a blood count, I do a creatinine, I do a urine routine, I do a sugar, I also do is amylase. A serum amylase is a very important test to diagnose pancreatitis. Pancreatitis is also a cause of severe pain which you should not miss. So once those things are done, the patient goes home and then comes back to me with the sonography or the CT scan report. Now once I see the CT scan, I have to decide whether to give him conservative treatment or ask him for any surgical intervention. So this is an answer to the common question the patient asks, doctor how are you going to treat me? मेरा stone खुद से निकल जाएगा कि नहीं? मेरा stone के लिए कुछ दवाई देना है कि नहीं? मेरा stone के लिए कुछ operation करना पड़ेगा कि नहीं? Now if there is the outflow, we will take it in three parts. One is a stone in the kidney, other is a stone in the ureter, and then the stone in the bladder. First coming to the kidney stone part. Now kidney, if there is a stone in the kidney which is say around 5 mm, 6 mm or 7 mm, we do not do anything because they can pass down with water, with a good amount of fluid, with just waiting. But if the patient comes with pain and there is a 7 mm, 8 mm stone which is blocking the outflow of the kidney, if he doesn't subside with medicine, I may have to take him for intervention and remove the stone. This is a kidney stone. But if there is incidentally detected large stone in the kidney, for example, there is 15 mm stone in the kidney, or even say 10 mm stone in the kidney, can a 10 mm stone come out through a 5 mm tube? It cannot. So I have to do a intervention to remove this stone. So this is the kidney stone. Then coming to the ureteric stone, which is the most important presentation to us with pain. Kidney stone, as I told you, doesn't come to us with pain, it is incidentally detected. So for a ureteric stone, we find out if there is hydronephrosis. How much is the hydronephrosis? If there is infection, so WBC count is right, patient is having fever, patient is having a lot of pain in the back, so these are infection. So fever, infection. So if the stone is very large, so if the size of the ureter is say 5 mm, 6 mm, if a stone is having say 9 mm, can it come out? No, very unlikely if it is in the upper ureter. So these are the indications when this patient will require surgery. So to say what are the indications of surgery, one is a large stone, one is the kidney is infected, when there is a bilateral stones. So in this case we ask for a urgent intervention. So what is a large? What is the definition of large? So there are various guidelines for it. There are some guidelines, American or European, who say that if the stone is in the upper ureter and if it is more than 6 mm or 7 mm, you should go and remove it in upper ureteric stones, especially because their chances of coming down is less if it is more than 7 mm. But for a stone in the lower ureter, even for a 8 mm stone or a 10 mm stone, waiting is not bad. If you wait, for example, a stone which you said 10 mm on CT scan may be a 10 into 6 mm stone. That basically makes it a 6 mm stone. Waiting for it to pass with a lot of fluid intake with tamsulosin or alpha blocker is a prudent treatment to do. So unless there is a large stone in the upper ureter, I don't ask for immediate surgery. For a lower ureteric stone which is as big as 10 mm also, I ask for the patient to have conservative treatment. What I mean by conservative treatment is patient will drink a lot of water, patient will have paracetamol for initial 2 or 3 days to relieve pain, and then the patient will continue on alpha blocker, tamsulosin, alphazocin, silodosin drug. So drugs which relaxes the ureter, allowing the stone to pass. And then I see the patient back after 3 weeks with a sonography to see if the stone has descended down, stone has passed. Accordingly I take a call for the next treatment. So after a month, if the stone is in the same place, it has not moved an inch, then you have to go and remove it endoscopically. So this part, if this answers the stone about the ureter. About the bladder, if there is a stone in the bladder, if it is say 8 mm, 9 mm, you can wait for it to pass if it is not causing symptoms. But if it's a large stone, the outflow of the bladder is not so large that it will, a 12 mm stone from the bladder will pass. Even if it has come down from the kidney into the bladder, it cannot pass further. So I have to go and remove it. Now how do we go and remove it? To answer that question, what we do today is known as endoscopy. Now, endoscopy is what? We go and visualize the stone inside the kidney and then we blast it or we fragment it or what you call dust it off with laser. This is known as endoscopic removal of the stone. Now, there are different endoscopic procedures. For example, for the bladder, there is just a cystoscopy and a laser fragmentation of the stone. For the ureter, there is ureteroscopy and removal of the stone. We fragment with laser fragmentation today. Although we used to do it with lithotripsy, lithotrity once upon a time. Nowadays, we just fragment with laser, which is more effective and which gives better results also. There is less chance of the stone left band, stone migrating in the kidney, so we do a laser fragmentation. Now, other part is that when the stone has gone to the kidney, when the stone is in the kidney. When the stone is in the kidney, we can do a flexible scopy from below. Means there is a endoscope goes in, it can flex up, down, anywhere inside the kidney. This is known as a flexible ureteroendoscopy. Once you do a flexible, we see the stone, we visualize the stone and break it with laser. Or sometimes we may make a small hole from the back into the kidney. This is known as a mini perk or ultra mini perk. This is what we have today. With this, through this tract which we have created from the outside into the kidney, we use endoscope to insert through the tract. We go inside, see the stone, and we dust it off with laser. This is the common methods. Another important thing is DGA stent. After removal of the stent in the ureter, many times we put in something which is known as a DGA stent. What is a DGA stent? So if there is a tube, so tube has a stone somewhere inside, so it cause some injury or damage or what you call some inflammation of the ureter. So after the stone is removed, so this part of, so this, if you visualize, this is the ureter. So this part is injured. So in process of healing, it may join together. So if I have a 5 mm tube also, if I can put something in between, so in the healing process it cannot close down, so there is no stricture. This is the most important reason we put in a stent. We put in a stent also for bilateral stone causes renal failure, so stent will drain the urine from the kidney down to the bladder. We also put in a stent as infection in the kidney, so drain the kidney. So this is what the stent is done. So but after a normal ureteric stone, after the surgery, you put in a stent in which the thread is connected. The thread comes up to the penis or the urethra outside. So after 4 or 5 days without a second admission, you can hold the thread and pull out the stent. This is what you do. So this is about the small part about medical and intervention for stones. The next important question which comes after that is, how do I prevent stones in future? What should I do so there is no stones in future? The important part of stone prevention is drinking more of water. The most important cause of stone formation is perhaps if you drink less, so the urine is more concentrated and the stone forms in it. Number 2, when there is a lot of salt in the diet. A lot of salt in the diet, because we have seen that chemically when there is a lot of sodium chloride in our diet, we tend to form more stones because we excrete more calcium in the urine. So less salt if you take. Third, weight loss. So people who are diabetic, who are obese, their urines are acidic. So acidic urines is more of stone formation. So to prevent stone formation, one thing is more of liquid intake, less of salt intake, reduction of weight, control of diabetes, and having a low protein diet. Your diet should not be high, very high in protein. Our normal protein requirement is around 1 milligram per kg per day. So 80 kilo person will require 80 grams of protein per day, perhaps only 1 egg. So now if he's taken say 300 grams of chicken every day, he will have stones in all likelihood. So it is not to be done. So this is the part of prevention. Now many of my patients ask me, doctor, can I take a beer to remove my stones? A very important question for this. Now about the beer part, what is that key? Whatever liquid you take, your kidney is going to form urine and you are going to throw the urine out. The urine will flush the stone. That's the principle of giving liquid. Beer is also a liquid, but ironically if you are taking a lot of beer, beer is rich in oxalates. So for a long term, beer is not good for stones. Number 2, if you are drinking only say a pint of beer and not taking fluid, you get dehydrated many times. So it is again bad for the stones. So per se there is no evidence that beer will cause expulsion in the stones. Although beer is a diuretic, all alcohols are diuretic. So better, I would not suggest anybody to take beer for removing the stones. But if somebody is having a routine beer just like that because he wants to have it, is okay. But beer to flush the stone is not okay. I gave you the reason why. Because one is that beer has rich in oxalates. Beer causes a lot of dehydration because not taking other fluid with it. So better not to take the beer for this. So to conclude, we had a talk about kidney stones, how to manage the initial pain, how you diagnose it. So once the initial pain is managed, patient should go to a good urologist near him so that he can diagnose the stone associated complications is not, if there is any, and also give him a line of management to treat the stone. Thank you very much.